Eboke. I'm a junior at Battle Mountain, and I kind of came up with the idea to create this project, which aims to kind of provide extra resources to high schoolers in the Valley, and just build off of what they already know and to be more specific and comprehensive. Yeah.
I'm Amari Stepanek. I'm helping Rudy out with this. I'm doing like managing social media as well as Rudy. Yeah, and helping out with meetings.
And okay, is everybody all part of the same high school?
Mm-hmm.
Okay.
We both go to Battle Mountain High School.
Okay. Are you a junior as well?
I'm a sophomore, sorry.
You're a sophomore. Okay, it's okay. Okay, so do we want to get started?
Yeah, whenever you're ready.
Ready? Okay. So I'm Betsy Cairo. I have my doctorate is in human reproduction, and I am a certified sexuality educator through AASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists. I have supervisory standing, which means I can supervise other people to become certified in this specialty. I own the only cryobank in Colorado, and I started it about 30 years ago. I also have a nonprofit called 𝘬𝘭𝘢𝘴𝘦𝘴, which specializes in reproductive health education for all ages. We have a textbook that I sent to Rudy, and it is designed at the high school level. I taught this at the college level for about over 21 years. Wrote a textbook for that class, and then I kind of pared it down and made it suitable for high schools. And so we have a high school textbook as well. And this is a semester-long curriculum that we have designed and promoted so that, like, y'all are here because you wanted more. That's why it's called Extended Sex Ed. And we feel like there's a lot more to learn. So that's why we feel like a semester class is warranted. We have piloted this class a couple of times. The students seem to really like it. The teachers seem to really like the textbook and all the PowerPoints that come with it. And that's sort of what our goal is to just get more knowledge into the hands of the people who need it the most. Are there any questions before I begin? Okay, so tonight I'm going to present briefly, but at any given time you can interrupt me and ask questions. I'm going to present briefly on STIs, contraception, and preserving your fertility, especially in this age of all the toxins and chemicals that we're exposed to. And then also we have trans folks who are transitioning earlier than before. So I'll go ahead and get started. I am going to see if I can't bring that up. Can you see that? Can you see my screen?
Yeah,
you can see it. Okay, great. All right, so sexually transmitted infections, previously called sexually transmitted diseases, but you'll still hear them called both of those things, have been around since dirt, so nothing new there. But one of the reasons that we really need to talk about this topic, especially to folks your age, is because you can see that even though people in your age aren't as sexually active as the general population, the STIs that they bring to the table are half of the reported cases. And in some regard, that's really not your fault because you aren't given a lot of information or knowledge to help reduce this exposure or risk. And when we talk about STIs, people always feel shame. And part of the reason they feel shame is because of how they're transmitted. And we use the word sexually. So we don't necessarily make fun of people who have emphysema. We don't make fun of heart disease, but for some reason we feel that it's okay to shame people when they get an STI. And part of this is twofold. One is called the social factor. And social factors are things like isolation, moral judgment or issues, healthcare systems that aren't able to meet the needs of this population. And then when we look at alcohol and drug abuse and misuse, it can impair our decision making. And so when we look at moral issues, we're often talking about what we consider acceptable sexual behavior. And some people say it's not okay. Some people say, don't judge me. We definitely have disagreements about sex education, or what we call reproductive health education, because reproductive health education is a bigger umbrella than just sex ed. It covers everything, including sexual health. So we tend to refer to it as reproductive health education and just take the stigma of sex ed out of the equation. And then when we talk about moral and medical issues, some people are so ashamed that they might have an STI that they feel they'll be judged if they go to the hospital or by the medical community, so they don't go, which just makes it worse. So when we're talking about STDs, we're looking at two factors. We have biological, which I'm going to talk about briefly, but when you combine that with the social, these are those two factors. So you have social and you have biological. And biological falls into the category of asymptomatic, meaning you don't know you have it, so you pass it on. And then we also have infections that are now becoming resistant to strains that we have with respect to treatments. Gonorrhea is a very curable disease, but it's becoming very resistant to all the antibiotics we have on the market. And a new treatment is now being tested with CBD. As you know, or hopefully you know, CBD comes from marijuana. It has no mind-altering effects at all, but it's showing great promise in treating some of the diseases like gonorrhea and MRSA and Legionnaire's disease. And this is a pretty big breakthrough. And then we have curable versus treatable. And with respect to that, we have diseases that if you get it, we can treat you and it'll go away completely unless you get it again. And then we have those that if you get the disease, it's treatable, meaning you'll always have it, but we can hopefully treat the symptoms. So anything bacterial is curable and anything viral is treatable. And here's an easy list to look at with respect to curable versus treatable. And we have gonorrhea, chlamydia, trichomoniasis, syphilis, PID, and anything over here is, as you'll see, has a virus attached to it. So HIV, or human immunodeficiency virus, hepatitis B, hepatitis C virus, herpes simplex virus, human papillomavirus, or HPV, and then pelvic inflammatory disease, as you can see, is on both sides of the fence. And so treatable really is anything with a virus. You're probably going to have it forever, although we are showing some real promises in completely removing hepatitis C from the body with some new, very expensive treatments, but they are showing a lot of promise. Human papillomavirus, or HPV, will also leave the body in about 98, 97% of the time, but some of the virus can still hang around and be in the body for a very long time. And pelvic inflammatory disease can be caused by both these types, and that's why they're on both sides of the fence. So how do we prevent the spread of all STIs? And in talking about that, we always talk about abstinence. And abstinence is defined differently by different organizations, maybe by different points of view. But abstinence truly is the concept of not touching another person at all sexually. So that means any type of physical contact you would have with somebody else in a sexual manner, including kissing, is not being abstinent. I know that we like to think of abstinence as maybe not having sex, and often we define sex as penis and vagina sex, but we know that there's a lot more to sex than just that. So abstinence is it's a worthy goal. And it's impractical because for some people, this is not going to be something they will practice for the rest of their life. For some people, they might, especially those who might identify as asexual. But it's kind of a hard goal to reach for the rest of your life. So then the next thing in helping the spread is to have safe sex, whether it's penis and vagina sex, oral sex, anal sex. We're looking at condoms, and the different types of condoms we have are outside condoms, which were previously known as male condoms, and we have inside condoms, which were previously known as female condoms, but now we just refer to them as outside and inside condoms. And condoms really work. They are an effective means to reduce your risk of sexually transmitted infections. They're not 100% effective. They just can't be, because you can have user error, the condom can break, or they're used improperly, but they can help reduce your risk. And then it's important to take a sexual history of the person you think you want to be sexual with. And that is before you decide to be sexual with this person. So taking a sexual history is finding out how many people this other person has been with, because that's an important piece of the puzzle of the person you're going to be with. If they've been with a lot of people, their risk is higher. If you've been with a lot of people, your risk is higher. That's not about shaming. That's just about knowledge. And so getting a sexual history is really important. Also, if you or your partner have had any history of any type of sexually transmitted infection, you would definitely want to know about that prior to becoming involved with this person. And then, of course, regular checkups are really important. Go see a healthcare provider, talk about what your symptoms are if you're having any, and be checked out. The really important thing to know about this is that a lot of the sexually transmitted infections don't have any symptoms. Some of the symptoms that we see can be in natal women, and some of the infections that we see that show symptoms can be in natal men, but a lot of them don't show up in either. And so checkups are really important. And then if you think you have a symptom, it's really important to get treatment, to see somebody, to talk to somebody, and to let your partner or partners know that you have been tested and found positive for an infection, and they need to be seen and be treated as well. And most importantly, being informed and being responsible. So if you think you're ready to be sexually involved with somebody, then you're ready to be informed and you're ready to be responsible. So as we talked about sexually transmitted infections, this is one of the things that can happen when you become sexually involved with somebody. The other thing that can happen is you can get pregnant. And so we're going to briefly talk about birth control. So there are a lot of different types of contraception or birth control. Hormonal, such as the pill, the shot, or the implant. Barrier, which can refer to external or internal condoms, or we can even talk about the diaphragm. Spermicide, which can be in a cream or an ointment or a foam, and this is always best if it's used with something else. Intrauterine devices like an IUD, these are referred to as long-acting reversible contraception. Or fertility awareness, which is not really for teenagers. And then the last but not least, sterilization, which is the final frontier. That means you're done having children or you never want to have children, and sterilization is your final option. I think any of these are good options. Some are better than others. But what's really important to understand about contraception is which is the best one. I get asked this question all the time in class. I get asked this question by my college students for years, and here is my answer. The best contraception is the one that you will use consistently and correctly. If that's a barrier method, then use that one. If it's the pill, use that one. If it's an IUD, use that one. But if we're going to look at the top 3 forms of contraception and their use in the United States, the pill comes in first, female sterilization or having your uterine tubes tied, and the outside condom. These are the top 3. The IUD comes in at number 4, and then everything else falls in after that. There is one other contraception that I think gets a lot of confusion around, and that is what we call emergency contraception. One of the first emergency contraceptions to hit the market most recently is called Plan B. And it's called Plan B for a reason, because it should never be Plan A. You shouldn't go into a situation going, well, if I have unprotected sexual activity, I'll just take Plan B. That's not what Plan B is for. Plan B is for when Plan A fails. You missed a pill, the condom broke, or unfortunately, if there was a sexual assault, this is where Plan B comes in. It's only used for emergencies. It won't delay fertility. But most importantly, and this is why I want everybody to understand, is it does not abort an established pregnancy. It's not the abortion pill. It has progesterone only in it, and therefore it will not make a pregnancy go away. It just affects the step prior to that, which is ovulation, and it affects the cycle in that form. What are the side effects of Plan B? Well, feeling sick to your stomach, abdominal pain, being tired, having headache, menstrual cramps, all of these can be part of that issue. If you take Plan B, some people have them worse than others, some people have no changes, and it may change the menstrual cycle for that month. It could make it longer, it could make it shorter. But also keep in mind, it will not protect you from STIs. Plan B was originally, when it was originally approved by FDA, you could only get it by prescription. And then it was approved for over-the-counter, which meant you could go up to the pharmacist and ask for it, but you had to be 18. And now it's approved for over-the-counter with an ID if you're 17 or older. Anything under that, you'll have to get a prescription. Plan B, one step, it can reduce your pregnancy in a very large range. And this depends on where you are in your cycle with respect to, is it your fertile time? How quickly did you catch your error? Did you go ahead and take Plan B right away? So the sooner you take it when you need it, the better the outcome. There's another emergency contraception out there that is only available by prescription, and this is called 𝘓𝘂. 𝘓𝘂 works a little bit more, has a little bit wider range of use than Plan B. Plan B can only be used up to around 72 hours post unprotected intercourse. 𝘓𝘂 works up to 5 days. It's only good for emergencies. It will not delay fertility. It certainly won't protect you from any STIs or STDs. The side effects are pretty much the same. And again, it's something that should not be used as a regular form of birth control. It should only be used in emergencies. So at this point, I would typically say, are there any questions? And if there aren't, I will move on. Okay, so one of the things that I like to talk about is fertility preservation. And what fertility preservation means is being able to have biological children when you're ready. And typically we talk about fertility preservation often in the older populations. So for instance, we might talk about women, natal women who are in their late 30s who are not ready to have children yet. So they might go and have all of their eggs, or many of their eggs taken from their ovaries, and those eggs are frozen. And then those eggs can be used later when they're ready to have a pregnancy. They would do in vitro fertilization with sperm, make an embryo and have that put in their uterus, and hopefully that a pregnancy takes place. But we also talk about fertility preservation for people who maybe are undergo cancer treatment. So there might be chemotherapy, there might be radiation, and these can definitely affect somebody's ability to get pregnant later on. And because I'm a reproductive biologist, this is one of the things that I see every day that people need to do. One of the growing populations that we see in fertility preservation are our trans youth. So when we have natal male that are transitioning to female, their goal is to shut down their testosterone, increase their estrogen, and transition in that respect. What happens when you do that, when you shut down the testicles with estrogen, is they stop producing sperm. We don't know on what level this is reversible. We do know it can be reversible once they would stop the estrogen, but we don't know how clearly the testicles will bounce back, start producing testosterone, and start producing sperm again. And so for a lot of these folks, what they do is they preserve sperm prior to undergoing their cross hormones. And this is sort of an involved process. So when we talk about doing this and how long it can store for, we can store sperm and oocytes that we know right now indefinitely, as long as it stays in the liquid nitrogen vapor or the liquid nitrogen liquid stage. When we talk about short-term storage, it typically means that you're going to store for less than a year. You're just doing this maybe prior to a surgery or prior to chemotherapy, and then you're going to get started after that having a family. Long-term storage is greater than 1 year. We have clients here that have stored or are storing, and they might be in their 20th year of storing with us. These tissues, these reproductive tissues, are regulated by the Food and Drug Administration, the FDA, which I'm sure you've heard a lot about, especially now that we're talking about COVID and the vaccination. And you know that FDA has given emergency use of these vaccines. The FDA is in the United States to look at pharmaceutical companies and see how their tests go and their trials to see if it's going to be safe for the public. But FDA also regulates things like types of surgeries, implants, and also any type of biologics like donated blood, and in my case, reproductive tissue. So storing sperm, and this is a pretty simple simplification, is that the patient would abstain, meaning there's no ejaculation for at least 3 days and not more than 7. And then the specimen would be collected into a sterile specimen container. And then we would process the specimen, the patient can leave, and then we'd repeat the above steps until satisfied with the number of specimens stored. We typically recommend storing as many as you possibly can with respect to time and money. The cost is relatively on the low end compared to any other type of assisted reproductive technology. Then storing oocytes or eggs is a lot more complicated. The patient would be put on birth control pills for about 25 days. This is to make the ovary really quiet and not ovulatory. And then there's going to be pre-retrieval blood work done after the last birth control pills. And then they would start fertility drugs. And then they would have ultrasounds. And sometimes they're going to have to stay on these fertility drugs for a couple of weeks. And these are typically injection form. And so that's a lot of needles in the arms and the legs, a lot of ultrasounds, and a lot of blood draws for seeing how the hormones are doing. Then they take a trigger shot, and then they have a retrieval, which is about 36 to 44 hours later. And the cost is much, much higher. But we haven't been able to store oocytes or eggs successfully until real recently, and quite successfully in about the last 10 years. So this is a real great breakthrough especially for trans folks who are transitioning from natal female to male. So FDA regulates this tissue only if you're not considered a sexually intimate partner. And since we talked about what that means about being sexually intimate, that's how FDA defines it. And unfortunately, they typically at this point really only define it in a heterosexual concept of cisgender folks. So we're thinking penis and vagina is considered sexually intimate. So there are two ways we can look at this. If you are a sexually intimate partner, FDA won't get in your way. If you stored sperm or you stored eggs and you're going to mix those with sperm or eggs with somebody that you're having sex with, FDA won't get in your way. There's no regulation. But if you are not going to do that, let's say you're going to take your sperm and you're going to mix it with a donated egg, then that makes you, and then you're going to have that carried by a gestational carrier, somebody who carries a pregnancy for you. FDA gets involved because they say none of these people were sexually intimate, and they run the risk of getting an infection from your tissue. And if that's the case, FDA wants an anonymous donor or a directed donor to be screened and quarantined. A gestational carrier is only somebody who carries a pregnancy. There's no genetic link to the fetus. They're just renting out their uterus or their womb for 9 months, and they are typically paid for that. A traditional surrogate is half the genetic material, also carries a pregnancy, and then would relinquish the baby to the intended parents. It can get really complicated, but there are a lot of different ways to make a baby. So how many combinations are there? Well, I put a few up here. I'm sure we could even get a little bit more complicated than this, but we can look at a sexually intimate couple. This often refers to opposite sex couples, and definitely we're talking cisgender, but it can include a lot of different categories as well. And they can use an anonymous donor sperm or directed donor and their partner's egg, or they can use their partner's sperm or an anonymous or directed donor's egg, or they can use anonymous or directed sperm and anonymous egg. And then the person who has the uterus would carry the pregnancy. We can have a lesbian couple who can use an anonymous donor sperm from a sperm bank, or they can have a directed donor, which is usually somebody they know or a friend or a family member, and they can use their own egg, or they can use an anonymous egg donor. You can have one partner carry the other partner's embryo and essentially be the gestational carrier. But again, FDA will be involved in this. And then we can have a gay couple where we would use one partner will use their sperm and go through traditional surrogate, or they can use a gestational carrier. And the only reason I'm going through all of this is because in the position that we are now with respect to trans awareness and gender fluidity and non-binary folks, is that a lot of this is becoming pretty commonplace. And I really want the younger generation to know that if they think that they want to have children in the future, this is an avenue they could potentially go down and not lose that ability to have a biological offspring of their own. Not everybody that identifies as trans or non-binary or gender fluid wants to have children. Not everybody who identifies as cisgender wants to have children. But I just want everybody to know, and especially the younger folks, that there are some options available, but it takes a little bit of effort and a little bit of time. So directed donors are definitely regulated by the FDA. FDA is not as current with respect to trans folks or gender identity than where the general public is at this point. So they're a little bit behind, and so they haven't really come out with definitions of what they consider sexually intimate. But again, it's often defined as a sharing of bodily fluids, especially sexual fluids. So Anonymous and directed donors definitely are regulated by the FDA, and proof of sexual intimacy from the tissue donor at the time of donation would be required. In my bank, we just have this person sign a form saying that they're sexually intimate with this other person, and we accept that as truth and we just move on. So what about other centers? Well, they feel the same way. It's not as if we wouldn't take somebody's word for them saying that they are sexually intimate, and typically just assigned consent is just more of a safety issue for everybody involved. So what about same-sex couples? Well, men having sex with men, and again, FDA is defining this as identified as assigned male at birth. So men having sex with men is considered sexually intimate. Women having sex with women, and these are girls identified as girls at birth, has not been addressed as something that is considered sexually intimate. And then, as again, I'm always talking about cisgender versus transgender. Most centers are not concerned about cisgender, but male to female transition can change the type of bodily fluids exchanged depending on the type of surgery, especially if there is not only top surgery, but bottom surgery as well. So it becomes pretty complicated, but it's not impossible. And I think what is interesting is that one of the things that FDA is always talking about is sexual identity. And I want to talk briefly about what that means with respect to people who identify as trans. So when you have somebody who identifies as female who was assigned male at birth, but they haven't transitioned, they haven't changed pronouns, it's something that they're either keeping to themselves or still working out, and they are somebody who is attracted to women, then when they go out in public, society sees them as heterosexual. After they transition and they present as female and they still are attracted to women and they go out in public, society sees them as lesbian. But nothing for them changed. The only thing that changed for them is the authenticity of their appearance. And so sexual identity is a complicated term to be using when we just talk about sexual behavior. And that's where the FDA is still probably stumbling around on that. So we always have to take into account what's going to happen down the road after somebody stores prior to transitioning. So I'm not going to go through these, but these are some of the STDs that I talked about earlier with respect to sexually transmitted infections. And these are the things that have to be screened for when we are looking at storing sperm for somebody that might be used with somebody that they are not sexually intimate. So you can see they're all here: HIV, syphilis, gonorrhea, chlamydia, hepatitis B, hepatitis C, and maybe some you haven't even heard of. For women, it's the same thing, although they are given a little bit of leeway on some other tests. So now, who owns the tissue? If you are a minor, meaning under the age of 18, your guardian and or parent will have to co-sign your consent to store your reproductive tissue. Your guardian or your parent loses jurisdiction over your reproductive tissue once you turn 18, even if your parent or guardian is still paying the storage bill. And this is something we have to explain to parents and guardians over and over again, that they do not own the tissue. It is not theirs to be in charge of, even if they're paying the bill. They can't even, after the patient turns 18, they can't even have access to that, to the chart. So how long can tissue be stored? Well, tissue can be stored indefinitely as long as it stays within the liquid nitrogen or the liquid nitrogen vapor. So to wrap up, I just want to point out that we have covered STDs or STIs, we covered contraception, and we covered fertility preservation. And I hope you will see that these things kind of all tie together with respect to your reproductive health and your sexual health. And again, usually at this time, I take questions. Are there any questions?
Do you think you could talk a little bit about other types of protection like dental dams and things like that?
I can. If you like, I can pull up another slide. I can actually go through all of those. What in particular, like, are you talking about dental dams with respect to performing oral sex on somebody who has a vulva? Is that kind of where your question's going?
Sure, yeah.
Okay, so when we talk about, when we talked about barrier method, I talked about internal condoms and external condoms, and I didn't talk about dental dams, but just to rehash, an internal condom, which was previously known as a male condom, is typically used on a penis that is going to be inserted into a vagina or an anus, or if somebody is performing oral sex on somebody who has a penis, a male condom is important. Dental dams work in the same way without penetration. So a dental dam is typically a rectangular shaped piece of, it can be made out of latex. They can also be made out of non-latex, and they are stretched over the area of the vulva, and so that it protects the receiving person from any type of sexually transmitted infection that they could be getting from the person who is giving oral sex to the person with the vulva. So there will be a barrier between the mouth and the vulva. So it protects both parties. Does that answer your question?
Yeah, thank you.
You're welcome. Anybody else?
I have a question.
Okay.
I'm Erica Gilbert. I'm a counselor at the school where Amari and Rudy go to school. And I'm wondering, as a teenager, obviously thinking about having children is in the far future. So what advice or guidance would you give to trans students in thinking about this and knowing that it's far in the future, fertility, etc.? What guidance would you provide them at this point?
That's a really, really good question. I can tell you that a lot of the trans youth that we see in the cryobank it's probably, a lot of it is driven by the parent and or guardian. And so you have this relationship with their kids that are helping them think about the future of what that looks like for them with respect to wanting to reproduce. And so I guess the conversation I would have with is when you have folks that identify as transgender, I think it's important for them to understand that their world is not either or. It doesn't have to be you don't transition so you can have kids in the future, or you do transition and you can't have kids in the future. I don't think for us that conversation should be an either or. It should be both. If you think you might want to have biological children in the future, then fertility preservation is definitely something that you would want to think about. And I think that this would be something that would be really important to discuss with your guardian and or parent, and or a counselor such as you, or a therapist, or all the above. I think what's really important to remember is that with respect to fertility preservation, is if this person, as they grow older, decide that they do not want to have biological children, they can just send us a consent to throw it away, and we will. It doesn't go anywhere else. It's theirs. It belongs to them. And they can choose to keep storing it, or they can choose to throw it away. But I think the important piece of that equation is that at that point now that they're older and are thinking about things down the line, is they have a choice. They didn't have to make one final choice about their reproductive future at 13 or at 15. They can actually kind of put that on the back burner and have it there in the shadows or wherever, you know, in the back of their mind as an availability for them down the road. And I think that that's the most important option, especially when you're facing some pretty big stuff as a trans youth about all the things that you're changing in your life. This should not be something that you should have to think about giving up.
Yeah, thank you. That's, I think that's helpful. Thinking about just kind of leaving options open in the future.
And that's what it does. It doesn't require, yeah, it just gives options. It's kind of no different. It's sort of along the same line of anybody doing fertility preservation. So we have youth come in that are as young as 13 who have testicular cancer, and their treatments, surgeries, et cetera, can render them sterile for life. And so when we have them in our office, you know, it's explained to them that this allows them the potential to have biological children later on, or they can choose not to, and again, have them discarded when they make that decision. And so fertility preservation is just about kind of a snapshot in time, allowing somebody who's facing some pretty big life changes at that moment in their life to not have to worry about fertility down the road, because we're going to take care of that for you. We're going to do the fertility preservation, and we're going to be here for you when you make a decision on what that looks like for you. Are there any other questions? Because I love questions, so ask away.
I do have another question if no one else is jumping in.
Ask away.
So in thinking about this same topic, with parents so involved in this process, what have you seen as successful or helpful ways to have this conversation with parents, or start the conversation with parents? What advice could you give to teenagers in that regard?
Advice giving to teenagers as far as approaching parents to have this conversation, or advice to parents as far as approaching this conversation?
I would personally love to hear both, but I think for the purposes of this call, particularly for teenagers.
Right. So I think if we're talking specifically about trans youth, is that specifically where we're talking, and not just youth facing sterility due to cancer? So if we're specifically, so if we're specifically speaking in this population of trans youth, let's say we've already established this conversation where they've explained to the parents, guardians in their house that they identify as gender nonconforming or gender fluid or transgender, or all three, but that changes their trajectory of their life moving forward. That's a really big conversation to have initially. And so in some regards, that big hurdle has probably been crossed. And then the next question is, and I think I might want to have children, can we talk about what that looks like? And I would hope that because all of these big conversations already taken place, the next conversation of, I would think I would like to have children, would also be welcomed in that conversation, in that arena. I think what's important to understand is that if that conversation isn't brought up about fertility preservation, then it should be brought up with the healthcare provider that you're seeing, because this is really not new stuff. This is information that is out there, and healthcare providers that are dealing with trans youth, trans folks in general, should know about the option of fertility preservation, and it should be presented to all of their youth and their patients. The most important thing to remember here, which is really hard to because it walks a real fine line, is if we're talking about parents, they have this process that they're going through as well with respect to this conversation now that they've just had with their kiddo. And they're on another level of thinking of, well, this is, what do we do with this? And what does that mean down the road? And I can tell you some parents start thinking about things like long-term relationships, marriage, children, grandchildren, that sort of thing. And so sometimes the fertility preservation piece is actually pushed on the other end by parents because they are thinking down the road for their kiddo about what they think might be important for them because it was important for them when they were a youth or when they decided, you know, as a reproductive being that they wanted to have children. And so it's a lot to talk about all at once, and it's definitely not one conversation. It's a lot of conversations, but I think that the more that our youth know about what their options are down the road, I definitely think it's a conversation worth bringing up. And I would have to say that most of the parents that I've seen with respect to their kids coming in for cryopreservation are really excited and relieved that this is available for them, just so that their kids have all the options that they had in the future about whether or not they wanted to have a biological family. But also keep in mind that for some people, biological family isn't an option or isn't important because, you know, adopting, fostering, all of those things can also fulfill that part of your life besides having a biological family.
Awesome, thank you.
You're welcome. That's good questions.
Cool. If nobody else has any questions right now, we have a question from an anonymous Google form that we have linked on our Instagram.
Okay.
And it says, can you only lose your virginity if you have vaginal sex, or do other types of sex count as losing your virginity as well?
Oh, wow, this is such a great question. First of all, virginity is a really interesting word that I'm hopeful someday we won't ever use. But that hasn't happened yet in my lifetime. So to answer the question, your generation and generations previous have been sort of burdened with the concept of penis and vagina virgin or vaginal virgin. And so you have this vaginal virgin concept, you have this anal virgin concept, and you have this oral virgin concept. And then when this abstinence-only education wave took over, their focus really was on vaginal virginity, meaning penis and vagina sex. So they didn't really talk about anal sex or oral sex. And so what happened was a lot of youth who wanted to experiment with sexual activity, but wanted to not be shamed by what they were hearing around their peers or their family about vaginal virginity, because that was your V card. So you got to hang on to your V card if you didn't have penis and vagina sex, but you could experiment with oral sex or anal sex. And so to answer the question, virginity is not about penis and vagina sex. And it's really, there's a lot of different sexual activity. And so if we were talking about men having sex with men, and I'm talking about the concept of being assigned sex male at birth. So men having sex with men, that's sexual activity, even if there isn't penetration. Men having sex with women is sexual activity, even if there isn't vaginal penetration, if there's oral sex or finger sex, having fondling sex, dry rubbing sex. Then we have two women having sex, and we can talk about scissoring or simultaneous oral sex, or two women performing oral sex on each other. This is all sexual activity. But what's really important to understand is kissing is a sexual activity. And kissing is considered one of the most sensual and intimate sexual activities because it's typically face-to-face. It's a very close contact with somebody. You might even be whispering or talking while it's taking place. So to answer your question is, virginity is not just based on penis and vagina sex, because I think it's important for people to understand that all sexual activity is valid sexual activity, and there is no one is higher, has better status than the other.
Cool, thank you. I feel like that's such an interesting topic, because I feel like a lot of people today are like, oh, it depends on, you know, your individual definition. And I feel like a lot of young people don't really know what that is for themselves. And so I feel like your answer did a really good job of talking about all of the different aspects without kind of just generalizing it as kind of a personal definition, which is true as well, but also I think a little confusing for a lot of young people.
Exactly. And I think we have to really be clear here about the difference between sexual identity and sexual behavior, right? So sexual identity, so we talk about sexual orientation, right? We talk about heterosexual, homosexual, bisexual, pansexual, asexual. We talk about sexual orientation versus sexual identity. So sexual identity is the ownership, or what we call the proclamation, or the ownership of that orientation. So do you identify as straight? Do you identify as gay, asexual, pansexual? Do you behave in that manner? So we have a lot of people who don't understand the difference between sexual behavior and sexual identity. And so I used to ask my students, can a man who identifies as gay have sex with a woman and still identify as gay? And the answer is yes. A man who identifies as straight can have sex with men and still identify as straight. And I think that this is a really important thing that everybody needs to understand, that sexual identity and sexual behavior are not the same thing. And you will never know somebody's sexual identity. You'll only really know somebody's sexual behavior. Only they'll know their sexual identity. And so when we see two women kissing in a bar, we think, oh, they're lesbian. If we see two men kissing in a bar, we say they're gay. But all we're really saying is that two women kissing in a bar denotes lesbian activity. It doesn't tell us what their sexual identity is. And that's really an important thing to understand with respect to sexual behavior, sexual identity, and then starting to classify it with respect to virginity and that sort of thing. It's an interesting distinction that I think people really need to pay attention to and make sure that they don't make conclusions based on how somebody behaves.
Yeah, I totally agree. I feel like that's also a really important thing for young people to hear. Yeah.
Good. Yeah. And that also goes back to what we talked about earlier with respect to birth control and sexually transmitted infections. Birth control is important for a lot of reasons, and not just for the type of sexual orientation or sexual identity you think you have, because again, it can be a different type of behavior. So if you have somebody who maybe identifies as lesbian, but is curious and has penis and vagina sex, they can get pregnant. And so it's important that birth control is not just identified for people who are having who identify as heterosexual, but birth control is important for people who are having types of behavior that can result in pregnancy. And so when we talk about birth control, it's not about your sexual identity, it's about your sexual behavior. That's the same thing with STDs or STIs. It doesn't matter what type of sexual behavior you're having, you can always risk getting an STD. So to say that lesbians have the lowest risk of an STD can be true if their sexual behavior is only with another natal female or someone who identifies as female who's not having any other type of interaction, especially in the heterosexual world. But basically, we have to understand that when we talk about sexual orientation, sexual identity, sexual behavior, and then gender identity, it becomes this whole sort of Venn diagram of pick your adventure. And so the important thing is, especially in today's presentation, is to understand that when I talk about STDs and I talk about sex and I talk about contraception, this applies to everybody, regardless of identity, sexual behavior, gender identity, or gender expression. It can happen to anybody.
Yeah. Does anybody have any other questions, or
I have a question.
Okay.
So this might be a little silly, but what is vaginismus and how is that different from just not liking PIV?
Oh, great question. I'm impressed that you know what vaginismus is, or that you've even heard this term. So vaginismus is this involuntary contraction of the vaginal muscles when there's penetration. And that can be any type of penetration. It can be penetration of a tampon. It can be penetration of a finger. It can be penetration of a vibrator. It can be penetration of a penis. And so, but it's typically an involuntary contraction, meaning you can have somebody who has a vagina who wants to have PIV. They want to have penetrative sex, but their vagina won't allow it because it's this involuntary, severe contraction that with any type of penetration causes extreme discomfort. And so it can be a real mental confusion because this person may really want PIV or penis and vagina sex, but their vagina won't let them. That's vaginismus. When somebody is having penis and vagina sex and they're not digging it, and the vagina is not having involuntary contractions, that's different. That's like, just don't dig this, not my gig, don't like it. That's different than vaginismus. Vaginismus is a medical condition that's an involuntary contraction of the vaginal muscles upon any type of penetration. Some of these people who have vaginismus can't even use a tampon because it's that uncomfortable. Did that explain it for you?
Yeah, thank you.
You're welcome. It's a great question.
cool. Do we have any other questions? Or are we ready to start wrapping up?
Just want to say that that was an amazing presentation. Thank you so much, Betsy.
You're
this
welcome.
is Annabelle.
Yeah, thank you.
And Rudy
You're
and
welcome.
Amari, great job leading this project. And thank you so much to everyone who attended. And if there aren't any more questions, then we'll just wait for you guys to leave.
Okay. And I love doing it. Thanks for inviting me. If you ever want any other topics of discussion, I know that Rudy has our textbook. There's a lot of chapters in there, and would love to present on anything else if you are so inclined. So take care, everybody. And again, if your listeners or if anybody's watching this, they can reach me at Betsy at 𝘚𝘦𝘹.org. I know that Rudy has my email as well, or you can reach me at 970-667-990-990-6, or you can go to our website at 𝘚𝘦𝘹.us. Thank you.
Thank you so much for speaking. You did a great job.
Thank you, Betsy.
Enjoyed it. You're welcome.
Thank you. And
Good
we
night,
will share your
everybody.
book and that contact information when we post the video, if that's okay.
Absolutely. That's wonderful. And then that'd be great. Thank you so much.
All right.
Take care, everybody.
Have a great night, everyone.
You too. Thank you.